Very welcome, everybody, to the Medtronic Symposium on EBC Main. We will use the next couple of quarters to discuss this very important trial within bifurcation PCI. With us, we have as chair Goran Stankovic. We do have in the panel Francesco Burzotta, myself, Mirvat Alasnag, and Azeem Latib. And we do have Thierry Lefèvre as chat master if you would like to pose some questions from the audience and from the online audience. But I would like to start by giving the word over to the president of the EBC, Goran Stankovic.
Thank you very much, Jens. I think we have really privilege to discuss within our meeting our latest study, and I think one of the most impactful regarding future plans and promotion of provisional stepwise layer strategy as a philosophy. According to the results of the study, which are neutral, and we are expecting longer-term follow-up to probably have even better outcome, hopefully. I would like to start by a presentation of Francesco Burzotta. We intentionally selected the Resolute Onyx, and he will clarify what were the reasons to do that. Francesco, floor is yours.
Ladies and gentlemen, I'm Francesco Burzotta from Rome, Italy, and I will speak on Resolute Onyx for left main and bifurcation stenting. These are my conflicts of interest disclosure, and I would like to start questioning which stent is ideal for bifurcations. So, on historical perspective, these are the John Ormiston's bench tests. The way to compare the suitability of drug-eluting stent was just to perform ballooning across them. So is maximal site cell size the only stent characteristic influencing bifurcation interventions? For sure, it is not. So in 2014, there was the Onyx European launch, and I had the pleasure to perform the first bench tests in my cath lab showing the impact of the selection of the stent platform in the main vessel and the rewiring site to the final conformation of the Onyx stent. So now in 2021, we have many updates regarding Onyx for unprotected left main and bifurcation PCI, and we will review them together. This is the Onyx stent design. We have this sinusoid formed wire that with laser fused struts that creates a unique drug-eluting stent platform. And if we look at the bifurcation stenting, what we most of the time do is just to implant, starting by implanting the stenting crossover across the side branch takeoff, and most of the time there is a bending so that this aspect of the Onyx may really facilitate the allocation of the stent across. Then, for the main vessel, what is recommended by EBC sizing according to the distal reference, and we should then adjust the proximal part with the POT according to the proximal main vessel. If we look at the different stents by different manufacturers, the Resolute Onyx has the unique features of having 4 different sizes with the specific structure. And here there is the chart. I like very much the idea of calling those different platforms as small, medium, large, and extra large, like the T-shirt. And in the perspective of main vessel treatment, what is important is the fact that with the 2.0, we may reach 3.5. With the 2.75 by POT, we have 4. With the 3.5, we may reach 5.0. And with the 4.5, we may reach 6.0. So really incredible way to adapt perfectly our drug-eluting stent to the different size of the main vessel. Other aspect is for sure the side branch management. The stents may jail the side branch in different way. This is the way done by the Onyx platform. And after the ballooning, we may have this fantastic opening. How great is this opening? Well, this is the maximum side branch diameter expansion. So really huge side branch can be treated by perfect stent struts removal. And this is the final aspect we may have with the pot, with the kissing balloon and the POT. This is a bench test, and looking at the clinical practice, we know that bifurcation can be treated both by implanting the stent in the main vessel, so this is provisional pot, this is requiring a RPOT, but also sometimes by inverted provisional, by implanting the stent from the main vessel toward the side branch. And this is the fantastic adaptation of the Onyx stent documented into the visible art. Other aspect is the fact that the particularity of this stent is its round shape, and this may influence the crossing. And this is a bench test showing how it is for sure more easy to advance balloon across the side branch when you have round struts. Other aspect is the platinum iridium core that may increase visibility. Very important point when we have to add a stent for the side branch. Final remark regarding the left main. We know that ostium is very stiff tissue, very particular aortic tissue, so compression resistance should be adapted, and you see that there was an improvement over time from Resolute integrity to the Onyx large. And also, since there can be interaction with the guiding catheter, there is also multiple links here that may reduce longitudinal compression chances. And this is the final appearance we may hope to have into our patients and as practice in the visible art. Thank you for your attention.
Thank you very much, Francesco. That was really terrific. I would like to invite now David Hildick-Smith, the PI of the EBC Main, to share the screen and present the impact of the EBC Main and open issues. Dave.
So, thank you very much, Goran. That's great. I hope you can see the screen and the slides clearly. So I thought I'd just give 5 minutes on where we're at with EBC Main. Obviously, it's been, I think, a big success in terms of generating discussion. And just to remind people about the outcome with this study, it was 460 odd patients who went into the study, randomized to provisional versus a systematic dual stenting approach for bifurcation left main stem disease. And here are the one-year results, which I think you know well, but I just reprise them very briefly to show essentially no statistical difference between the two groups at 1 year. Numerically more revascularization in the two-stent group. Okay, so at the time, what were the conclusions that we had from this study? So firstly, we had numerically fewer serious adverse events with stepwise provisional. We had less use of consumables. Importantly, only 20% of patients in the provisional group required that second stent, even though all the cases the operators were happy to put a second stent if they were randomized to two stents. So for me, the most important message of the study was that actually it's not necessary to prejudge the issue and start with what is a non-provisional and obligate two-stent approach. So for me, that was the strongest message. Patients obviously equally well treated at 1 year with the stepwise layered provisional approach. So I think that leads to the open questions here. And there are a number. Firstly, why is that different to DK Crush 5? And I think we've already had the chance to discuss that a little bit in terms of the complexity of the patients anatomically, the length of the side branch disease, the what we might call the philosophy bias between the European and the Chinese camps, if you like, in terms of how to approach these patients. So there are a number of reasons for that. Of course, interestingly, will the outcome be maintained at 3 years? We've seen in previous studies some divergence of curves in favor of a less metal implant, a simpler approach over time with some of the studies that go back a decade. So that'll obviously be interesting. I think very importantly for the EBC, we have to change the perception that 2 stents in a provisional strategy is a bailout or a failure. It's not. It's the final common pathway of the stepwise layered provisional approach. And equally, how do we encourage people to have the resolve to start a complex case provisional? They often will look at it and go, well, that needs 2 stents. So they prejudge the issue and they don't necessarily have the courage. People think of provisional as a simpler approach, but it's not. It's a logical approach and it takes things step by step until you have a good result. That may be with 1 stent, maybe with 1 stent and a kiss, it may be with 2 stents. I think one of the things I sometimes hear is that people feel there's a clinical difference in outcomes between an upfront 2-stent strategy and a provisional technique that ends up with 2 stents. And I don't personally believe that's plausible, and I think that's selection bias in the non-randomized papers that allude to that. But it's a perception which we have to address. And then, when is disease sufficiently complex that 2 stents are fundamentally inevitable? Whether or not you decide to do a provisional or a dedicated, when is that point where the side branch or side vessel mandates stenting in its own right? For some reason, DK crush, I mean, obviously the trials will be done, so I understand that, but there's a sense that DK crush is a specific go-to 2-stent strategy. I think we have to challenge that and say, fundamentally, is there any real plausible reason to suppose that an optimally done DK crush is systematically superior to an optimally done mini culotte? Personally, I don't think so. There's the question which everyone raises of, would the results be better with IVUS and OCT? This is a little bit like the surgeons sort of always saying, oh, well, yes, I always do bilateral internal mammary grafts. It's like us saying, oh, I always use IVUS. But actually in the clinical trial, you didn't always use IVUS. It was 35%. Would all the results be better systematically with IVUS? Is it clear to us? I'm not sure that it is. Is it clear to us what trials should be done next to help further the field? And those are my thoughts about the status of the study and the open questions, and we will open it up now for wider discussion.
Yeah, thank you very much, Dave. Excellent as usually. We are in a think tank meeting, but there are many people connected online, and I agree with you that do not prejudge the issue is one of the main messages, but please elaborate more on this message.
Well, I think the problem is that people often look at the anatomy and before they start, they go, okay, this is a DK crush type case, or okay, this is a 2-stent case. I'm not going to be able to do it with a single stent. But actually, quite often, and those of us who did the study, and in fact, I remember a live case not long ago where everyone on the panel saying, well, you're definitely going to be putting 2 stents in here. And we did the case, put the first stent in, did the pot, did a kiss, and then it was like, oh, we finished. Yeah, we don't need that second stent. And this happens a lot. And yet, of course, if you start with an obligate 2-stent strategy by stenting the side branch, well, of course, as Jens usually likes to say, if you start with 1 stent, you can end with 2. If you start with 2 stents, you can't end up with 1. So, I just think it's a shame that people feel obliged to, and actually I think part of that is not a determination to do a more complex procedure, but it's actually because people are slightly afraid of approaching it provisionally and having to adapt as they go and feel more comfortable sticking in a stent straight away into the side branch. And I think that comes with practice and repetition of finding, actually, here you go provisional and you get to the point where you can stop. So So I think we have some work to do as the EBC to try and promote that message.
Thank you. I like also very much the provisional pathway as defined by Jens. And if he can, again, elaborate more on that one, because I think this is one of the strongest messages that we need to convince people that provisional doesn't mean single stent strategy. Jens, could you please take the floor?
This is an excellent discussion, and we always end in this stage. But I think there's one thing more we should underline, and the EBC Main trial was not a negative trial; it was a neutral trial, and that's extremely important when we discuss it. The result of the trial is actually clear, but statistically it's neutral, and that means that there's no penalty of choosing one technique over the other. And we need to have that in the back of our head every time we are discussing these things. And then it's much more easy to say, how is the beauty of the provisional pathway, and what is the beauty of DK cross? And this is actually some of the more discussion on preferences from operators. So from the provisional pathway, there is one thing more from EBC Main trial that is important, and it is that this is 1 year follow-up. And this is extremely important because from all registries and all other trials and with a long time follow-up, it seems that more metal is more prone to have events down the line. So 5 years follow-up may show that there is another signal in the trial if we actually think that 2 stents is more prone to restenosis, stent thrombosis, double layers of stent with medication and that kind of things down the line. And that's come back to what David actually said, that it's not possible to end with 1 stent if you start with 2. So then the beauty of the provisional pathway is that you start simple and move forward. The beauty of DK cross would be that if you're really scared of losing the side branch, then it's a safe procedure to do, but it implicates that you need to end with 2 stents to take care of the main branch afterwards, when you have actually put a lot of effort into securing the side branch. But if we go to the provisional pathway, you could just stent the side branch first, do it all reversely. That actually will scare, or maybe some of our colleagues and ourselves will lose the courage for what would happen if we close the main branch. And then we have to remember that on top of the provisional pathway, we always have rescue procedures if we would lose the main branch for this instance, which means that we have a double wire, we have 2 wires, and we can go behind the stent struts with a balloon and open up again and then continue the procedure. So there are rescue issues that if you have them, you can actually embark on a quite risky 1 stent strategy first, because you have a tool to solve the problem. And then you can, yeah. So this is actually the philosophical discussion between those 2.
Yeah, thank you very much. Just to sum up all this, I'd like to ask Mirvat, in 2021, in your perspective, what are the upfront indications for 2 stent strategy, Mirvat?
I think the most important is looking at the side branch and its significance. So if the side branch is a large, for example, circumflex that's dominant, I would think twice, and it has disease at the ostium. And the other indication for me is if it's a difficult access. So if it's angulated, a calcium plug, what have you, I would consider an upfront 2 stent strategy just to secure that side branch. And if I may just say one tiny comment, a provisional strategy requires expertise, actually, because you need to think on your feet. When you're upfront 2 stent strategy, you know what you're doing and you're a robot. You just go in there and do what you need to do. But if you need to improvise and if you need to rescue a main branch or a side branch, it takes experience. And that's why EBC Main had a minimum operator experience requirement to enroll.
Thank you very much, Mirvat. But we learned this morning from Professor Seruyus that optimal medical management of our patients is also extremely important. So I'm asking now Azeem Latib to speak about DAPT and bifurcations. Azeem, please take the floor.
Hi, this is Azeem Latib from Montefiore Medical Center in New York. It's a real pleasure to be back again at EBC and to talk to you during this Medtronic symposium. I'm going to be talking to you about dual antiplatelet therapy after bifurcation PCI. These are my conflicts of interest. So when we think about bifurcation lesions and we think about dual antiplatelet therapy, our natural instinct is to think that these patients require longer durations of dual antiplatelet therapy because we're dealing with lesions that are more complex, where flow may be turbulent, where there may be stent under expansion or malapposition, and where there may be more metal around the bifurcation. And historically, more metal around the bifurcation has been associated with the concern for an increased risk of stent thrombosis. There have been a number of studies in the past that have suggested that the risk of stent thrombosis is increased with 2 stents at the bifurcation, and so we should be prolonging our dual antiplatelet therapy. However, as we continue to perform PCI in more elderly patients, we also have become more concerned about the risks of bleeding, in particular in patients who are at high bleeding risk. Unfortunately, there are no randomized controlled trials specifically looking at DAPT in bifurcation lesions. And so the best we can do is use sub-analyses of randomized controlled trials or retrospective studies to inform our decisions. On this table published by Zimmerino and colleagues in Neurointervention this year, you see a summary of the data we can use to inform those decisions. So you see the pool analysis by Justino, specifically looking at complex lesions, suggesting that long-term DAPT reduces the risk of MACE and complex PCI. The data by the sub-analysis of the DAPT study by Rob Ye, showing again that long-term DAPT reduces MI and stent thrombosis, but increases bleeding, and this is more evidence in complex lesions, to then more studies more specifically looking at bifurcation lesions, such as the COBUS-2 registry, that looked only at bifurcation lesions and showed that after propensity matching, the risk of death or MI was lower in long versus short-term DAPT, long being more than 12 months. And then the EBC registry by Zimmerino and colleagues, also looking at over 5,000 patients treated for their bifurcations and looking at different durations of DAPT, showing that long-term DAPT was associated with a lower risk of MACE. Many of the studies consistently either show no difference or a protective effect from longer-term DAPT, but at the risk of an increased rate of bleeding. So we still sit with this conundrum about how do we balance the increased risk of bleeding versus the increased risk of ischemic events in this complex lesion. Well, since we are at a Medtronic symposium, what's the data for the Medtronic stent? Well, the data we have so far comes from this bifurcation analysis done by Matt Price and colleagues, looking at the Resolute Onyx post-approval study, which was a prospective multi-center single-arm trial in which they looked at 205 bifurcation lesions. These were lesions majority treated with a provisional approach, with only 3.4% of cases requiring double stenting. So maybe not the most complex lesion, bifurcation lesions, because they could be treated with a provisional approach. However, these were done well. Majority had POT, post-dilatation 71%, kissing inflation 18%. And when you look at the clinical outcomes at 1 year, the outcomes with the Onyx stent bifurcation was really good, with a TVF and TLF rate just above 6% and a 0% rate of stent thrombosis at 1 year. When you compare true bifurcations to non-true bifurcation lesions, there were really no difference in clinical outcomes, suggesting again that irrespective of whether disease involves both branches or not, the outcomes may be good as long as you imply you're doing a provisional approach. Well, this doesn't really answer the question as to whether we can abbreviate DAPT duration in patients treated with Onyx in a bifurcation. Well, the only data we have will be presented at TCT in a month's time, and that will be a sub-analysis of the Onyx 1 Clear Onyx 1 Clear study. Just to remind you, the Onyx 1 randomized study was an outside of the US randomized study looking at 30 days of DAPT in patients treated with either Onyx 1 or the BioFreedom stent. And the Onyx One Clear was a single-arm study done in the United States, looking at patients who had no events at 30 days after implantation of the Onyx, who would then stop their DAPT after 30 days. Obviously, these were all patients at high bleeding risk. When you looked at the 1,500 patients in the Onyx One Clear study, about 14.5%, that is 218, had a bifurcation lesion treated. Again, these were majority, probably simple bifurcations. 89% were treated with a provisional technique and only 11% with a two-stent technique, which is probably reflective of our current practice. When you looked at single antiplatelet usage after 1 month, it was 97% for patients with and without bifurcations. So I think this data will really inform us as to whether we can shorten DAPT in high bleeding risk patients who are treated for bifurcation, particularly if they're treated with a single stent approach. I also like this algorithm proposal from Marco and colleagues on DAPT duration. And what they've tried to do is try to really summarize what many of us do in clinical practice, right? When we try and think about whether we can, how long to give patients DAPT, the questions we ask ourselves are, is this a patient with stable coronary artery disease, or is this a patient treated for ACS? Those with ACS will probably require longer durations of DAPT. Then, is this a single stent approach or double stent approach? And generally, we'd assume that patients with a double stent approach will require a longer duration of DAPT. And then they also looked at whether this is a high bleeding risk or not. Patients at a high bleeding risk will try and abbreviate the DAPT. And the last one, which I think is extremely important, that Mark and colleagues highlight, is whether intracoronary imaging was used. I really believe that if you're going to be considering shortening DAPT in patients treated for bifurcation lesion, particularly if you treat them with two stents, then intracoronary imaging is mandatory to really be sure that you've implanted your stents correctly. There's no malapposition, and there's, more importantly, no stent under expansion or struts that are hanging in the carina that may impact flow. And so if you want to shorten DAPT in patients at high bleeding risk, I would say that intracoronary imaging is an important part of that strategy and the decision making. So hopefully these few slides give you sort of what my approach is to DAPT in these patients. I like this algorithm because it really answers the 3 or 4 important questions I take into account when treating complex lesions and thinking about shortening DAPT, which is their presentation, the complexity of the approach I use, so double stenting versus single stenting, the bleeding risk of the patient, and then finally whether I use intracoronary imaging or not, which in my practice, I use intracoronary imaging in over 80% of cases. It helps me to inform my decisions. Thank you for the opportunity to talk to you today, and I look forward to meeting you again at EBC in person in the future. Bye-bye.
That was terrific, Azeem. Thank you very much. One short comment. You did not speak much about single antiplatelet therapy once you stop with DAPT. What is your personal practice? Which kind of single antiplatelet therapy you recommend?
Yeah, so we actually did a sub-analysis in Onyx One where we looked at this. We compared patients who continued on aspirin only or Plavix only after 30 days. And really, we were unable to find any difference with stent thrombosis or any difference for myocardial infarction. We did, however, find a slight increase of cardiac death with Plavix only. And so the concern it highlighted was, here you take somebody where you've put a couple of stents into, you stop their aspirin, leave them in Plavix, and we're not testing for Plavix resistance anymore, really. So, was that slight increase of death possibly due to Plavix resistance? We don't really know because it wasn't also associated with the increased risk of death or MI. So I really think it's up to the operator what their preference is. We've generally in New York been stopping the Plavix and continuing with aspirin.
Thank you very much, Azeem. Dave, Jens, any final comments?
Well, one final comment could be that we again face this problem. We need maybe more individualized medicine with a lot of input before we make the decision on DAPT. Because this was an excellent presentation of how we do if we treat a population and actually will have an effect in a population on a better level than not. And maybe we could be more precise with precision medicine, actually taking care of both of the procedure complexity, but also the patient's risk of bleeding and thrombosis. So that might be a way forward in the future to be even more clear on what to advocate.
Thank you very much. With that, I would like to thank you all for excellent session, and I thank Medtronic for organizing this symposium. I wish you a successful rest of the meeting.
Thanks, bye-bye.
Bye-bye.